Okay, let's talk about pleural effusions. This is a topic that will definitely be on your shelf. You're going to have to know certain things. I'm going to show you what you have to know, and then we're going to go over some tricks that can help you maybe answer some more complicated questions. So, a few general rules here. We're going to be talking about either transudative or exudative effusions. Transudative is going to be the kind of effusion you see with heart failure or nephrotic syndrome, and ascites with liver failure can also cause transudative lung effusions. And again, these are going to be relatively acellular. They're not going to have a lot of protein. They're going to be basically just clear fluid. And the key to knowing you're dealing with a transudative effusion, if it's bilateral. Then we have our exudative. If it's unilateral, immediately you're going to think it's more likely to be, an exudate. But we can't just look at an effusion and say, oh, it's on one side, so it's exudative, so we have Light's criteria. You probably will be pimped on Light's criteria, when you're in the hospital. But for the shelf, I know it may seem like something you don't need to know, but you need to know Light's criteria. And that starts with knowing that there are three of them, and only one of the criteria has to be positive to make it an exudative effusion. And those three criteria are right here: protein in the pleural fluid compared to the serum, LDH to serum LDH ratio greater than 0.6. So I don't need to read that to you. You can see it. Again, the point is only one needs to be positive. And just to give you some reference to why these are, kind of what we're dealing with, is that whenever you have inflammation associated with your pleural effusion, that's going to lead to increased capillary permeability, allowing protein and white blood cells to be released. And when white blood cells or bacteria enter into the pleural fluid, they're going to undergo anaerobic metabolism and increase lactate production. That's why your LDH can be high with an exudative effusion. All right. So how do we manage pleural effusions? The big key or word you need to know for management is the thoracentesis. And basically, this is just where we stick a needle in. It's where you have the classic picture of the patient, leaning forward on the table, and we stick the needle in, and you drain out the fluid. Now, we can do a thoracentesis for therapeutic reasons, or we can do it for diagnostic purposes. On the shelf, it's going to be mostly a diagnostic, thoracentesis, where we can send the fluid off and get cell counts in labs. And when we're doing Light's criteria, those results all come as a result of you doing the thoracentesis. Now, the other thing with effusion management is going to be, when do we put in a drain to allow the effusion to continuously drain out for a couple of days? And the obvious first thing that comes to mind is when you're dealing with an infection or a parapneumonic effusion, which is associated with a pneumonia. Now, I'm going to go through this in a minute, but you're not going to drain every single parapneumonic effusion, because there's uncomplicated and complicated parapneumonic effusions. And of course, the worst end of that is the empyema, which is literally frank pus in the pleura. And we'll talk more about that in a minute. The other types of effusions that are exudative and automatically need to have a drain put in, if you happen to encounter this on the shelf, it's a malignant effusion and also a tuberculous effusion. Both of those need to be drained. And again, we're not just talking about putting in a thoracentesis needle, because that's only going to drain out, however many milliliters of fluid at one time. We need to leave a catheter drain in there for a couple of days. That's what I'm saying when I say drainage. So you need to know the general procedure for performing a thoracentesis. And I know this seems silly, but I remember I had a question on my shelf about how to put in a chest tube and where you do it, and which ribs you go in between and above the rib, all that good stuff. And the thoracentesis is a little bit more straightforward than that. We'll talk about that other one later. The point is, though, you insert the thoracentesis needle from the back in the mid-clavicular line. And again, you have the patient sitting down, leaning forward while you do this. But before you do it, you need to figure out where the effusion starts. And again, on your exam, you're tapping on your finger and you hear the transition to dull, which suggests that that's where the fluid's starting. And on the shelf, they may tell you that there's a transition to a dull point at a certain rib, and you're going to want to put the needle in the intercostal space beneath where the transition to dull started, because we obviously don't want to put it in above where it's dull, because that's a great way to cause a pneumothorax. Also here, make sure you go in above the lower rib, and that's going to be the same with any of these procedures where we're putting a needle into the lung, because the vascular bundle, nerve, vein, and artery. Another word about transudative effusions, just the classic kind of case here. You've got a patient who has pretty clear heart failure, and you know you've got the bilateral effusions on the x-ray, and then you look at the thoracentesis results, and there's basically no LDH because you don't have any white blood cells in there, because it's not an inflammatory effusion. And also, what I really want to point out here is that normal pleural fluid pH is 7.45, and normal pleural fluid glucose should be about what the serum glucose is, and we'll say between 60 and 100. So anytime your glucose is below 60, that would be abnormal in the pleural fluid. And if the pH is below 7.2, look at me here, Mr. Pathoma drawn. So, yeah. So below 7.2 for pH is going to be clearly abnormal, and we're going to go into that more in a minute. So what would you do if somebody has a transudative effusion with heart failure? Again, it's going to be bilateral, and the first thing is Lasix, because you want to diurese them, pump out that fluid. And depending on how much fluid is in there, you can do a therapeutic thoracentesis to literally re-expand the lung, because if there's enough fluid in there, a couple of liters as you can see here, that's enough to completely compress the lung, make it hard to breathe. So you get it, therapeutic. Got it? Good, love it. Next thing. So this is kind of where the meat is for this, and this right here, I just wanted you to see what it's going to look like on the shelf. And what I'm trying to show you here is that they're going to have to give you a serum LDH value and a serum protein value, and then they're also going to have to give you the corresponding pleural fluid values after doing a thoracentesis for LDH and protein. And we have the Leitz criteria greater than 0.5, greater than 0.6, and you might be worried that you're going to have to calculate something, but as you can see here, it's very obvious that the pleural fluid protein is more than half. 4.2 is more than half of what would be half of 5.8. So that's enough to get a positive Leitz criteria. And if you look at the LDH, 520 in the pleural fluid is greater than the LDH in the serum. So again, that's more than 0.6, or more than the half the upper limit of normal in the serum. So we can conclude by 2 of Leitz criteria that this is an exudative effusion. And again, I'm just showing you how this could be phrased in a question, how the values are going to look to you. And if you're doing UWorld or the MixSAP question book, you're going to see plenty of questions with pleural effusion applying Leitz criteria. So now we'll do a case here with a pneumonia and obviously a parapneumonic effusion, which is going to be probably the most common thing you're going to encounter with effusions on the shelf. So just to we'll just dig into this here. So we have somebody, and we've done the chest x-ray, and there's consolidation, right? So we already know they have a pneumonia. They've had symptoms for 2 or 3 days, so that's potentially how long this pleural effusion has been developing. So one thing that you need to remember is that when someone has a parapneumonic effusion, you want to do 2 x-rays of the chest, one when they're sitting up and one when they're lying in the lateral decubitus position. And that allows us to see if the pleural fluid is shifting with gravity, and that would mean it's free flowing if it does. If the effusion does not shift with gravity, you're dealing with what you call loculated pleural effusion, and that is going to be really suggestive, if not pathognomonic, for an empyema. We'll get to that in a second. So what do you do for this person here? Obviously they need antibiotics, so let's just go ahead and agree on that. So that means we can get rid of this one, and we can get rid of we can get rid of that one. And then the other thing here is, what are we going to do for this person's parapneumonic effusion? Because there are 2 types of parapneumonic effusions that are not empyemas: complicated and uncomplicated. Now, both of those different types of parapneumonic effusions are going to have positive Leitz criteria. They're both going to be exudative. So we have to rely on the pleural fluid pH and the pleural fluid glucose to let us know if we have a complicated or uncomplicated exudative parapneumonic effusion. So the key here is that if the pH is less than 7.2, which it is here, and if the glucose is less than 60, bingo, you have a complicated parapneumonic effusion. And the big thing here is that these complicated effusions are very likely to progress into an empyema if they are not drained. So that means they need to have a drain inserted. But that's not enough. You also need to give them antibiotics because they have a pneumonia, so they're going to get antibiotics. So point here is that look at those two values. That's going to tell you if they need to have a permanent, not a permanent drain, but a temporary drain inserted to let that pleural fluid kind of continuously flow out of there. And the other thing would be is if it were an uncomplicated parapneumonic effusion, you could have just done antibiotics with observation. So sort of just going through that one more time. 3 categories: uncomplicated, complicated. We discussed this. And the big thing here is we're trying to not let the empyema form. And remember that all 3 of these are exudative. And with the uncomplicated pleural effusion or parapneumonic effusion, the idea here is that you've had inflammation and it caused an effusion to form, but the kind of concept here is that a few bacteria may have gotten in there, but not many, and it's very unlikely that it's going to lead to a full-on empyema. Whereas with the complicated pleural effusion, we feel very strongly that that needs to be drained or else it will become an empyema. Then if you're thinking complicated parapneumonic versus empyema, how can we tell? And complicated parapneumonic effusions are sort of theoretically defined as we think bacteria are kind of continuously coming into the pleural space, but not necessarily enough to cause the formation of frank pus, nor are they enough to give us positive cultures from the pleural fluid. But again, we have to drain them. I can't say that enough. You must drain them. And with the empyema, in the clinical vignette, if they tell you that somebody has had symptoms, cough, fever for over a week or several days, and then they have an effusion on the x-ray, more likely automatically that it's had enough time to form an empyema. And I think that the complicated thing about your shelf will be, should you just put a drain in and give them antibiotics like you would for a complicated parapneumonic effusion, or should they get thoracoscopic surgery? So what I think you'll see on the test is they'll tell you that the person had a upright and lateral X-ray, and there was clearly loculated pleural effusion there. And let's say the question will tell you that they put a chest tube, or not a chest tube, but a drain in, but nothing came out. The drain just, was useless. And they ask you, what should you do next? And the answer here will be, you need to do, it's called VATS, Video Assisted Thoracoscopic Surgery. And you'll have to do that to break up the loculations and the fibrosis from the empyema. And it's less likely you're going to see that on the shelf, but I want you to be aware of when surgery is indicated to treat an empyema. Okay? So then if we're talking about, and with the previous slide here, when you're talking about the parapneumonic effusions, those are going to be neutrophil predominant with the white blood cell differential because they're related to the pneumonia. But there's always an exception, and the exception is TB because it's always the exception. So when you have a tuberculous pleural effusion, there's going to be a predominance of lymphocytes. Okay? So that is something that you need to keep in mind right away. So when you have a vignette that describes somebody who immigrated from another country and they have constitutional symptoms, and then you do a chest x-ray and they have a massive pleural effusion because it will be big, then that's someone who you would suspect tuberculous effusion in. And when you do the thoracentesis, bingo, you have a predominance of lymphocytes. And another thing you want to know about a tuberculous effusion is that you can have an increased level of adenosine deaminase, which doesn't really mean anything to me, and I hope not to you either, because I looked it up and couldn't really figure out much about it. But if they tell you that the pleural fluid has an increased ADA level, that should suggest to you that this is tuberculosis. And the point I'm getting at here is that the question on the shelf may ask you to say, what test can I do to diagnose a tuberculosis pleural effusion? And the answer is you need to do a pleural biopsy because, and again, we'll just go over that briefly. Autoimmune conditions, lupus, rheumatoid arthritis, you need to know they can cause an effusion. I think that on your shelf, the most you'll be asked to do is recognize that, you know, the patient has rheumatoid arthritis, for example. They'll tell you, oh, here's an effusion. What's the most likely cause? And the vignette will say something about wrist pain or, joint inflammation, and that should lead you in that direction to choose that. Then with sarcoidosis, same thing, lymphocyte predominant, and you should have the classic vignette with the hilar adenopathy and elevated ACE levels, the rashes. So just be aware that that's another cause of lymphocyte predominant pleural effusions. And then a lymphoma or a lung mass, and I'm sorry I kind of wrote that poorly there, both of those can cause associated effusions. And something that I would recommend you know for the shelf is that if you're dealing with a cancer-related effusion, you should drain it and let it drain out, just like you would for a complicated parapneumonic effusion. And if you do have a question about a chylothorax where there's increased triglycerides, in the pleural fluid, it's likely that that's related to cancer, okay? But more than likely, they'll give you the pleural fluid values and they'll want you to tell them that you're dealing with a chylothorax. And very importantly, you must remember that pulmonary emboli can cause pleural effusions. And the classic thing here is going to be someone who develops new shortness of breath, they've been immobilized, all the risk factors, and they also get some pleuritic pain. And the pathophysiology here is that you have a distal infarction in the lung, and the infarction leads to inflammation and drainage of white blood cells and a little bit of blood, ultimately leading to a small effusion forming. And what you need to also be aware of is that it can be exudative. So this is a great opportunity for them to trick you and, just throw this in here to mess you up. So if it seems like someone has a pulmonary embolism, but you're reading this question and they have a pleural effusion, don't be fooled. You can have both. You can have a pulmonary embolism that causes a pleural effusion, and just make sure you're aware of that. And just in summary, be able to look at the x-ray and recognize kind of blunting of the costophrenic angle, the classic signs of an effusion on x-ray. And if it's bilateral, it's transudative. Know your Leib's criteria. Use a thoracentesis for diagnosis and potentially for therapeutic treatment. And again, complicated parapneumonic effusions. I cannot stress this to you enough. Be able to know what is complicated based on pH and glucose versus what is uncomplicated. And if it's uncomplicated, you give them antibiotics and you don't drain it. If it's complicated, you get in there and you drain it and you give them antibiotics. And if you do have an empyema, it's very likely, if you're asked to tell them more than just to diagnose it, they're probably going to want you to tell them that the patient is going to need surgery. Okay? Hope this was helpful.